and then retired from the Army after 33 years of credible service, including 2 combat tours in Iraq. His clinical and research interests span across the spectrum of pediatric thyroid disorders, including hyperthyroidism, hypothyroidism, thyroid hormone resistance. And within these fields, he's published more than 120 manuscripts, chapters, and reviews. And within the past year has also launched an international child and adolescent thyroid consortium to expand multi-center collaboration. He's a medical consultant for the Thyroid Cancer Survivors Association and the thyroid consultant for the PTB DICER-1 registry. And he will be talking to us today about PTEN and thyroid disease. We're very excited to have him.
Thank you, Suzanne. Can everyone see my slides and hear me?
Yes, we can.
Excellent. So just my disclosure, and of course, a thank you, one for the invitation. I'm always honored and excited to meet with families and patients and try to go over what we think as a group, as a community, and me, obviously, personally, what the best approach is. And we learn, from our patients and families every day. So your input is really, really important. I look forward to some of the questions. And then, of course, thanks to my team. Nothing happens without a team. And both the fabulous PTEN Center that Suzanne and Garrett Berdor put together with really a great group of people at CHOP, and my thyroid team in particular as well. So what I hope to do today is kind of just give a background of thyroid disease. And Dr. Ain went over some of this already. I'll give you a little bit more detail. But what I'm really going to focus on is how do you evaluate thyroid nodules and thyroid cancer in general? Because patients with PTEN fall into that category, and we shouldn't change what the evaluation of a nodule is just because of a person has PTEN or DICER-1, or just they developed a thyroid nodule just sporadically without an explanation. And then we'll go a little bit into surveillance and how do we evaluate these nodules and what the best approach is as far as surgery. So the goal, I think, for any patient that's at an increased risk to develop any disease, and in particular, this particular topic is thyroid nodules and thyroid cancer, is you want to catch the disease early, because then you have reduced need for the extent of treatment and a better outcome. So that has to be balanced with not performing too many tests, not performing too few tests, with the goal of optimizing outcomes and avoiding complications. And all of that has to put into the context of not driving people crazy. So you have to individualize how you approach this, both on the comfort and anxiety of the patient and family, but also on the provider. And that's really hard to predict. And that's why communication and back and forth communication, it's a two-way street, is really, really important, and why education is the key to hopefully settling anxiousness and an increase in comfort based on what the data shows for that particular disease. And that's what we'll go over. So patients with PTEN are at an increased risk of thyroid cancer. Everyone on the call understands that. The current published risk is 35% over your lifetime, and that's about, compared to the general population, which is about a 1% risk. 2 forms of thyroid cancer that develop, and I'll go over this in a little bit, a few more slides down the slide set, is papillary thyroid cancer and follicular thyroid cancer. So before you are diagnosed with a cancer, you're diagnosed with a nodule. And if you look at thyroid nodules and when people develop thyroid nodules, over your lifetime, if you have PTEN hamartoma tumor syndrome, you have a 70% risk of developing a thyroid nodule. Within the pediatric age group, which is defined as less than 19 years of age, there's about a 30% risk of patients with PTEN being found to have a nodule. If you look at that compared to the general population, and this is data from Ernie Mazzafari many years ago, looking at physical exam versus ultrasound, obviously ultrasound is more sensitive. So we can feel some things, we can see some nodules on exam, but if you have an ultrasound and you put it on a patient's neck, you obviously can discover things that you would not find just by pushing on the skin and pushing on the thyroid gland. And so for all of us, the general population, by the time we're 50 years of age, about 40% of us will have something found on ultrasound. And under age 20, so within the pediatric age group, about 10% of patients will have something found on a thyroid ultrasound. And the question is, what is it and what do you need to do about it? Prior to that, of course, you have a normal thyroid. Oh, let me go back one. So if you have a 35% lifetime risk of developing a thyroid cancer, that means that the flip of that equation is 65% likelihood that you may have benign disease. And you can have benign disease for your entire life. It doesn't mean that every patient with PTEN is going to develop thyroid cancer. So we really need to stratify what the approach is to evaluation and treatment. Prior to that, patients have a normal thyroid. And within the background of PTEN, as Dr. Eng already brought up, 25% risk of developing autoimmune thyroid disease. There's two forms, hypo, too little, hyper, too much. And I think in general, it's more common to have hypothyroidism. That's known by Hashimoto's thyroiditis. It's named after someone, Hakuro Hashimoto, a physician from Japan. The challenge, of course, for all of us is, when does this whole process start? Why does it start? Why doesn't it start for some patients? And why does it start earlier for some patients? And we have really no idea, unless Dr. Eng has an idea and I just haven't heard. But that's a great question that needs to be answered. And maybe there are other things besides PTEN, other markers that dictate or predict the likelihood an individual person will develop a nodule before another person, even within the same family. So because of that, there's been this broad range of when we should start surveillance, and Dr. Eng went into this a little bit, and it's gone from at the time of diagnosis to 18 years of age, at diagnosis or by 2 to 3 years of age, 7 years of age, 10 years of age, and you can let us know if this has been driving you crazy, because it drives all of us a little crazy, again, with the goal of catching things early but not driving us crazy. The most recent is 7 years of age as a general recommendation. So within that, again, we have to balance what the individual patient wants. If a patient comes to us and they have a child that's been recently diagnosed and they're younger than age 7 and they're interested in thyroid surveillance, I'm comfortable. I point of care ultrasound. We have it in clinic. We will perform an ultrasound to hopefully alleviate anxiousness. But if you're somewhere else and you're not sure, the current recommendation is 7 years of age, and that's based on the earliest diagnostic age when someone was diagnosed with a thyroid cancer. So some of this is just data accumulates over time, and the guidelines change. Actually, that's not some of it. That's probably all of it, and some of it is feedback from patients and families as well. It's a balance. So what about thyroid nodules? We're going to go into just what is a thyroid nodule and what makes it a higher risk or a lower risk, which nodules should undergo biopsy, which is a fine needle aspiration. How to use that information then to decide what's the risk of malignancy within that sample when you biopsy a thyroid nodule, and then what do you do about it? So in general, the majority of nodules are benign. They're not a cancer, even in patients with PTEN. And I showed you that data a couple slides ago. So not every nodule needs to undergo a biopsy, and not every nodule needs to undergo surgery. Some nodules can be followed even without performing a biopsy, and certainly without going directly to surgery. Within that setting, of course, if you have PTEN, you have not only a risk of developing nodules, but you have a risk of developing nodules both on the left side of your thyroid as well as the right side of your thyroid. So we call that bilateral disease. There's two sides to the thyroid. And so with that in mind, that does impact how many nodules should we biopsy. If you perform surgery, should we remove half the thyroid or should we remove the whole thyroid? And those are questions that are really important to discuss with your individual provider if you're diagnosed with a thyroid nodule and you're undergoing evaluation. So thyroid nodules and thyroid cancer, unfortunately, or fortunately, are asymptomatic. So patients are typically diagnosed with a thyroid nodule, again, whether you have PTEN or not, without any symptoms. Some people may feel like a lump when they're swallowing. Some people may see the nodule. So that is possible, but most of the time it's not pain, there's no discomfort, and most patients don't notice it at all. And so in some sense, this is, for patients without PTEN, a blindsiding event. All of a sudden you're feeling fine and someone says you have a nodule, and then someone wants to stick a needle in your neck, and then someone wants to remove your thyroid. And that's very difficult for patients because they're asymptomatic. Most patients with cancer have symptoms. They wonder why they feel terrible, and then we find the diagnosis, and it's not good news, but the patient then understands why they felt so crummy. And so that's the hard part in thyroid cancer. The nice part of thyroid cancer is the majority of patients, and then I'll go over the data, even in PTEN and even more so in PTEN, have high survival, 98% plus survival. So if you're diagnosed with thyroid cancer, it's slow growing, and the likelihood of survival is extraordinarily high, 98%. So the goal is not to biopsy everything, the goal is not to remove everything, but to catch things early and to not have complications. So there's a difference between a high risk to develop cancer, thyroid cancer in particular, and a high risk to develop invasive thyroid cancer. And I'll go over what that means, but essentially is the cancer just in your thyroid? That's non-invasive, or is it spreading to lymph nodes or distant sites? And that would be invasive thyroid cancer. So patients at a high risk of developing a thyroid nodule and thyroid cancer are patients exposed to radiation. Most of these patients had a different cancer. Radiation was used as part of their therapy. And so that increases the risk. The younger you are at exposure, the shorter the latency to develop the nodule and thyroid cancer, and the higher the likelihood of developing it. And then there are certain syndromes that are associated with an increased risk of developing thyroid nodules and thyroid cancer. Some of those are associated with other cancers. Those are predisposition syndromes, and some of them are just isolated familial thyroid cancer, where the only cancer that runs in the family is thyroid cancer, no other cancer is associated with it. And of course, within the tumor predisposition is PTEN, but then there's a number of others. I'm just listing two others here that involve the thyroid. One is DICER1, and the other is familial adenomatous polyposis. So thyroid cancer is divided into a couple different subsets. Differentiated thyroid cancer are cancers that develop from the normal thyroid follicles, a normal cell within the thyroid that's making thyroid hormone that undergoes a change in the DNA and the instructions for the cell that dictate how much it grows and whether not only if it grows and expands, but if it develops the ability to move, to metastasize. Within differentiated thyroid cancer, there's follicular thyroid cancer and papillary thyroid cancer. And for the most part, these do have different genetic backgrounds, but they look different under the microscope. And this is just pictures, photomicrographs showing what the differences are for classic PTC and classic follicular thyroid cancer. Medullary thyroid cancer actually is a type of cell in our thyroid that is not a normal thyroid cell as far as producing thyroid hormone. It's part of the neuroendocrine system. And so there are some patients that develop medullary thyroid cancer, not PTEN patients. But within pediatrics, most of those are associated with a different predisposition syndrome, as you can see listed there, which is MEN, is what we abbreviated. That's about 75% in pediatrics compared to 25%. In adults, it's flipped. But those are in general, the different types of thyroid cancer. Within PTEN, follicular thyroid cancer is overrepresented. So compared to someone without PTEN, a person with PTEN has an increased risk of follicular thyroid cancer, but the majority of patients with PTEN have papillary thyroid cancer. So within PTEN, most patients have differentiated thyroid cancer, most patients have papillary thyroid cancer, and a few more patients have follicular thyroid cancer than compared to a patient without PTEN. As I mentioned, there's this non-invasive, invasive form, and again, you can just see it spelled out there. Non-invasive, it doesn't spread. Invasive, it does spread outside of the thyroid. And for our invasives, there's different types of invasive thyroid cancer. Some are differentiated. They're still maintaining kind of the normal appearance and the normal function of a thyroid cell, and then poorly differentiated, which means they've gone down the cancer spectrum a little bit further, and they've lost some of the ability of a normal thyroid cell, and they've gained, it's a higher likelihood that those cells are going to spread and be a little bit more difficult to treat. For the non-invasives, there's a very low disease-specific mortality, and I mentioned that earlier. So according to NCI SEER data, which is national data with their tumor registry in the United States, but there are other ones in other countries, very low disease-specific mortality, which means most patients with differentiated thyroid cancer under age 55 in particular, at the time of diagnosis, have very high survival. So treatment complications are what we're trying to avoid, and they are related to who you go to for the evaluation and the treatment. So how do we approach surveillance, evaluation, and management? So it's a balance, as I mentioned earlier, catching it early and not doing too much, trying to avoid complications of the disease, and trying to avoid the complications of therapy, and then trying to put that all into the context of the individual patient and family. So when we published the American Thyroid Association guidelines in 2015, the pediatric guidelines, we tried, and kind of following the adult guidelines, to stratify who should undergo a biopsy, who should undergo surgery, and what type of surgery. And our first version of the guidelines published in 2015 were pretty good. We mostly focused on stratifying post surgery and the use of radioactive iodine. And currently we're working on the second version. We hope to have them out next year. And we're going to get a little bit into more detail about stratifying surgery. Does every patient need a total thyroidectomy? Does every patient need a lymph node biopsy and dissection? Or can you do a lobectomy? And PTEN will be part of those guidelines. And of course, we'll incorporate data that we've obtained between 2015 and now. So it all starts with an ultrasound. And I'm going to go over what some of the ultrasound appearances of nodules are. And when you're with your provider, there's no reason to not see the images so you understand what the nodule looks like, what the size is, what the composition is. Is it fluid? Is it solid? Is it mixed? So you have a better understanding of why someone is recommending to either surveil, continued ultrasound, or to undergo some type of evaluation, which the first step would be a fine needle aspiration. So our thyroid lives in the lower part of our neck. As I said, there's two sides to it. There's a right side, there's a left side, and then there's this little thing in the middle that connects the two sides with a weird name called the isthmus. It's the bridge. It connects the two sides. It's just under our skin. It's just above our collarbone, and it's wrapped around our windpipe. The thyroid system, just like every part of the endocrine system, is a feedback loop. So your thyroid makes thyroid hormone. The number next to the T is for thyroid, is how many iodines are attached. That's why it's important to have iodized salt. And so if these numbers go down, that's hypo. If these numbers go up, it's hyper. So that has to do with the T3 and the T4. And if these go down, the TSH goes up. It's a feedback loop. If these go up, the TSH goes down. So that's a nice way of thinking about if you're on thyroid medicine, what are we looking for? What are we treating? The medicine people go on when they have hypothyroidism is T4. Levothyroxine or Synthroid is T4. So when you do an ultrasound, this is what we're looking at. So if you take the transducer and you lay it across your neck, this is what you'll see. The skin is up at the top. The darker blackish, dark gray area is muscle. And then this bright gray upside down C or U or whatever letter it looks like is the thyroid gland. And this is one slice, totally normal. It should be bright gray and uniformly gray. Right next to the thyroid are the carotid arteries, one on each side, the jugular vein, and right behind the left lobe is the esophagus. So this is a normal appearing thyroid gland. And if you flip the transducer 90 degrees, this is what thyroid tissue looks like in long view, or sagittal view is what we call it. So on ultrasound, there's really only one thing that you can find that has almost a 0% risk of malignancy, unrelated to PTEN, unrelated to other predisposition syndromes, and those are cysts. They're nodules, but they have no cells in them. They're completely composed of fluid. They can be relatively big. This is probably a 1.5 centimeter thyroid cyst, or they can be really small, 2 to 3 millimeters. And they can sometimes have little bright spots that are floating in the black, in the fluid. And this is called a colloid cyst, and that's a comet tail artifact. When the ultrasound wave hits the stuff floating in the fluid, it makes it shake, and it gives you that little comet tail. 0% risk, no reason to do a biopsy, nothing to do with PTEN, just happened to find it because someone did an ultrasound. So at this spectrum of benign to malignant cancer, this is clearly benign, 100% benign. If you look at nodules, though, that there's a whole variety of them, and this is just showing you, 8 or something images, and there's obviously way more variety. But some of them, based on ultrasound, are in between. They don't look like benign. They're not a cancer, and they're certainly not a cancer, so they're in the middle, but we don't call it in the middle. We call it indeterminate. And so some of them are very low suspicion. This is spongiform. This is complex. The black is fluid. The solid is solid. So that's a mixed solid cystic. Some are completely solid. But most of these, if you notice, if you look at the edge, most of them have a smooth margin. And that's a good giveaway. So the two most important things to say risk, no risk, is fluid, 100% fluid, no risk. Mixed fluid, lower risk than solid. Solid, then it depends on what the solid looks like, what the margins look like, and there's a whole bunch of other factors that come into play. And these are nodules that you can look at if you're used to looking at them and say, that looks like a thyroid cancer. If you notice, they're darker gray, and instead of a smooth margin, they kind of have, we call it a lobulated margin or an invasive margin. Sometimes it looks like it's growing out of the thyroid tissue. Here's the muscle, here's the thyroid. Sometimes it has a bunch of these bright spots. So not every bright spot is a microcalcification, especially if it's in fluid. but this one happens to have a lot of microcalcifications. That's a papillary thyroid cancer. And then in this one, this is zoomed in. This is the thyroid over here. That's the nodule. And over here is a lymph node that's completely abnormal because it looks like thyroid tissue because it is. It has thyroid cancer that's spread to that lymph node. So they've come up with this system. It was first named after BIRADS, which was breast imaging reporting and data system, and they call it TIRADS. So it's not very fancy. They just changed the B for the T. And it just takes 5 things for a nodule, and it essentially says, you know, what's the risk? And you add up points. If you ever look at your ultrasound report, they might include TIRADS. TIRADS is nothing special. It's just a way of thinking about, is a nodule at lower risk or higher risk, and should you subsequently have a biopsy or not? And TIRADS, just like any other system that we could ever create, is only as good as the person who's obtaining the images, because it depends on who's holding the transducer and what images they're taking, and the person reading them. So there's nothing magic about that system. It's just a system to relate it. And it really does matter who's performing it and who's reading the images. So if we say someone has a nodule that's indeterminate or it looks concerning, then those are nodules we want to then take to the next step. And the next step is a fine needle aspiration. In adults, they mostly tell us just to hold still. They might use some numbing medicine on our skin. In pediatrics, it depends on the institute. At least at our institute, we usually use conscious sedation. It makes things much easier for the patient and the person who's doing the procedure and the family. It's just, there's no reason to have a traumatic event for a procedure that has a very low risk, and that's really important to get good results. And so we use conscious sedation and ultrasound guidance. There's a probe, and you know exactly where the needle's going. But just like ultrasound, and unfortunately, this is not a yes-no event, because they're only looking at cells. They're not looking at tissue, and the needle's like skinnier than the needle when we get a blood draw. So it's a very, very fine needle. You're only getting cells, and the cells can only tell you so much information. And so it's not a yes-no. There's actually 6 possible results from a biopsy, and within the middle of those are these gray zone lesions again, gray zone cytology, which we call indeterminate, and that's on up to 1/3 of our patients. And so before you have a biopsy, you have to understand it's not a yes-no. Up to 30% of us, 1/3 of us, you're going to get the procedure done, and you're still not going to know. It could be, it may not be, and there's 2 tiers within that system. The difficult part right now in pediatrics is the risk of malignancy. It really depends on who's doing the procedure and who's reading the slides. Once again, you're going to hear that same statement over and over again. And this table at the bottom is just showing you, 7 or so different studies from pediatric hospitals. And in the red box is risk of malignancy for category 3, category 4, category 5. And you can just go down the columns and see the broad variety for risk of malignancy. And that's really difficult. So you kind of have to know within your own practice what the risk is. And we as a community are working to improve that, trying to publish an atlas so we can reduce the variability between the risk of malignancy read for pediatric cytology across different institutes. Just to briefly explain why that is, it has to do with pre-test and post-test probability. And this is true for any test. So if you have a high likelihood, you shouldn't do a test unless you know what the result is, and you know what the likelihood of the result is. So if you just take a patient that has a low risk nodule, so if you take this red line up here and you perform an FNA, and it depends on how good the FNA is, it's going to be less reliable as far as how to interpret the results. And if you take a patient with a high risk, I look at their nodule, it looks like it's dark gray, it has lobulated margins, it might have those bright spots. It's a high likelihood of cancer. You do the biopsy, the result is more likely to be believable. And that kind of makes sense. But if you see it in a graph like this, I think it's easier to understand, like, how can they not know? They just stuck a needle into my thyroid or my son or daughter's thyroid, and they still don't have an answer. And that's the explanation why. So again, it matters which nodules you biopsy. It matters who's biopsying it, and it matters who's reading it. Every step of the way, the better you have an experienced team, the higher the likelihood and reliability of the result. So in a 6-tiered system, selection of patients for a nodule impacts the accuracy of the results. So just to finish things, and then we'll open it up for questions, you're now saying I'm going to undergo surgery. Most of the time you should have had an FNA prior, and that's something we can talk about. So some patients may go to surgery without, and that's an individual discussion, but as a generalization, should have an FNA before. What's the difference between a lobectomy and a thyroidectomy? So here's just a graphic representation. If you do a lobectomy, this is removing half the thyroid. In this case, it'd be removing the right lobe because all the images are reversed, right? A total is your whole thyroid's gone. And a subtotal we don't do very often, but that's what a subtotal is, removing part of one side, part of a lobe. What's the advantage of a lobectomy? Well, behind the thyroid are 4 glands that control calcium. So if you're not operating on one side, you have no risk of damaging or removing those. So no risk of hypocalcemia. There's 2 nerves that control our vocal cords. If you're on one side, you reduce the risk of damaging, the other nerve. So that reduces the risk of recurrent laryngeal nerve damage. And over a lifetime, many patients that have half a thyroid do not need medicine, 85%. So that's a nice reason to try to leave some normal tissue if you can. But, if you leave half a thyroid, that means you need continued surveillance. If you have a predisposition syndrome, which means you may need another FNA, you might need a second surgery down the road. And that's the disadvantage of lobectomy. The advantage of a total thyroidectomy is you get rid of it. It's gone. You don't have to worry about it. You know what the final diagnosis is if you have nodules, because there's less chance, it happens very rarely, but less chance that after they look at the tissue under the microscope, they won't know what it is. So biopsy, a third of the time, it's gray zone. Histology, surgical pathology, high likelihood, 98% likelihood you'll have a final diagnosis and no cancer, yes cancer or no cancer. And if it's gone, it's gone. You typically don't need continued surveillance if it's benign. If you have thyroid cancer, I'm not going to go into all those details, then you need continued surveillance, and we can talk about that if you have individual questions. When you go for surgery, you should ask your surgeon, what's the risk of complications with a total thyroidectomy? And they should be less than 3 to 5%. We've performed 800 thyroid surgeries at CHOP, 2 surgeons. Our complication rate is less than 1%, permanent complication rate. And so under the microscope, what it determines low invasive. So this is, again, thyroid trachea is in the middle, the windpipe. The thyroid is, upside down gray C or U. In the back of the right lobe is a nodule. It's solid, it has smooth margins. It's kind of a lower risk nodule, but one you'd biopsy. If you take it out, the likelihood is you'd have one of these 2 diagnoses, or 3, I should say. I could have put benign here, but if you have a thyroid cancer, this thing called a minimally invasive follicular thyroid cancer or an encapsulated follicular variant papillary thyroid cancer. I forgot the Y. You don't have to know the details, but those are the typical pathology. And these are typically associated with PTEN and as well as other changes in the DNA that are associated with these. Invasive are things that spread outside of the thyroid. So this is just a different person, again, showing the thyroid cancer in a lymph node over here. And there's a different form, a different list of different types of papillary thyroid cancer that are associated with it. And it's a different set of driver alterations, different changes in the DNA that are associated with these types of tumors. And so to take it out of the ultrasound and more complicated, what's the pathology, and put it into more of a cartoon version, non-invasive, the cancer is within the thyroid. And there's this thing called the AJCC-TNM. T is the thyroid nodule, N is lymph nodes, M is metastasis. And it just defines on the pathology where the tumor was, how big it was, and what it was behaving like. So non-invasive, it can be bigger, it can be smaller, but everything is within the thyroid. Invasive is sometimes the tumors are growing out of the thyroid. Sometimes they're invading into things next to the thyroid or wrapping around them, or it's spreading to lymph nodes. And here's a patient with a thyroid nodule, and here's a lymph node up here. And papillary thyroid cancer notoriously spreads to lymph nodes for many patients, but not all patients, in a predictable way. So we have lymph nodes, we have 250 our neck, and papillary thyroid cancer often spreads there. And if it spreads there, then there's a risk it could spread further. The second most common location would be the lungs. So within differentiated thyroid cancer, again, follicular, papillary, this AJCC-TNM thing just defined is just giving us, a way to talk to each other about how big it was, where it was spreading, are there lymph nodes involved, not involved, is there distant sites involved, not involved, and that's called the AJCC-TNM. With rare exception, patients with PTEN have non-invasive or lower invasive thyroid cancer. So that first picture I showed you with the minimally invasive FTC, the encapsulated follicular variant PTC, that's what's most commonly found in the 35% patients over your lifetime that develop a thyroid cancer. 5% or less are found to have spread to lymph nodes or distant metastasis. And that's based on a number of different papers. Dr. Eng included, published this. We've published it, lots of papers that have gone over that. Very uncommon to have haploid or differentiated thyroid cancer associated with PTEN spread outside of the thyroid, and certainly spread outside of regional lymph nodes. We call this the central neck, from the central neck. Rare to have it on the side and rare to have it in the lungs. Very, very, very uncommon. Nothing's impossible, but very uncommon. So what do we think about surgery for PTEN? Well, many patients have total thyroidectomy, and why? Because they have nodules on both sides and they don't want to have surveillance, or they have a background of autoimmune thyroid disease. So that's it is the most common surgery for patients that undergo it, but oftentimes you can delay it. It just depends if you have a nodule, how big it is, what it would need, if you do a biopsy, all those things that we've gone over. So to wrap things up and then to open it up for questions, what's the summary, the take-home messages for patients with PTEN? Increased risk for bilateral thyroid nodules, absolutely, both in pediatrics and adults. Increased risk for thyroid cancer, absolutely, over your lifetime, increased risk. Many nodules are not cancer, and they can be followed with ultrasound. You don't even have to biopsy them. And if you have a nodule and it's biopsy, it really does matter which ones are selected and who's reading the biopsy. For thyroid cancer, this is a slow-growing cancer, so it's asymptomatic. That's kind of troublesome, but a little bit of patience, a little bit of waiting and seeing what happens to these things is oftentimes in the best interest of the patient, because they can continue to not need medicine without being put at risk that the cancer is spreading. Very low likelihood that these cancers spread. So 90% or greater, if you have a thyroid cancer, it stays within the thyroid gland. Surveillance, as Dr. Eng went over, and the most recent NCCN guidelines suggest, ultrasound by 7 years of age. And in the paper that Dr. Eng is publishing, that I was lucky enough to review, which is really fabulous data, if you have a normal ultrasound, whether you're a pediatric patient or you're an adult, the current data that Dr. Eng is going to publish suggests that you could skip years, even up to 3 years, without increasing the risk that you're going to develop a nodule that's going to undergo, have a risk of cancer and a risk of spreading. It doesn't mean if you're more of an anxious person that you can't have an ultrasound every year, but all of us have, it's again, the overtreatment not drive everyone crazy. There's a very low risk if you have no nodules of waiting and kind of not doing it every year, just skipping years, even up to 3 years. Surgery, total thyroidectomy is more common than lobectomy, and really find a surgeon with a low risk of complications, a low rate of complications. And it's uncomfortable. I completely understand that, to ask a surgeon, but you can ask us, the endocrinologist, like, how many patients do we see with PTEN? How many patients do we see with nodules? How many patients do we treat with thyroid cancer? And you can ask the surgeon the same thing. It is in your interest to advocate and to ask. And everyone should be open to those questions. And if someone seems insulted or they're making stuff up, if you can, I would go somewhere else. Individualized care based on patient family comfort and anxiousness. And with that, I will end and we'll take some questions. And this is just a list of the fabulous people I'm lucky enough to work with at CHOP as far as the Thyroid Center, and most of the other fabulous people I'm lucky to work with the predisposition team. You're meeting, during the meeting in person or just via the virtual list of people who are giving presentations today. So with that, I'll end and I'm open for questions. Thank you.
I'm so sorry. Andy, I don't know if you heard that question. I think our room was muted. I apologize.
Yes,
You
I
mind
didn't hear
repeating?
it.
Sure. Sorry. First of all, thank you. I have 2 areas of concern. One is regarding children. I know that we established today that the guidelines changed slightly for ultrasounds. Is it the same way for blood work?
I guess the question would be what blood work. If we're talking about thyroid function testing, there is no set surveillance for thyroid function testing. So there is a 25% risk of, hypothyroidism or autoimmune thyroid disease, but you can clinically screen who should undergo thyroid function testing, blood testing. So it depends on the family history. It depends on the physical exam. If a patient looks up and you can see their thyroid gland, then that would be that's called a goiter. That's what a goiter means. It just means you can see the thyroid gland. It's enlarged. It doesn't tell you if it's working or not working. And so that's a person that we would, perform thyroid function testing, a TSH and a T4, and then there's antibodies you could check. Outside of that, the signs and symptoms of hypothyroidism are really non-specific. So if I list 4 of them, I think most of us in the crowd, starting with tiredness and fatigue, would worry we're hypothyroid, when in fact it's just life that's, we're all stretched too thin type of thing. So fatigue, cold intolerance, constipation, heavier periods for girls, with increased flow, that's just the beginning of the list. And the problem is you can have that and not have hypothyroidism. But if you have PTEN, you have an enlarged thyroid, you have any of those symptoms, especially if they're kind of new or they're adding up, then those are patients we would surveil. So hopefully that answers.
I have one triplet that is heavily followed and one that isn't. So I'm just worried at what the balance for him should be, because they don't necessarily, an 8-year-old doesn't always report, express what's going on.
Right. So again, I think that's the individual thing. So you have one person in your family, one of the triplets that's being screened and the other one who hasn't. I would, and you're worried, I would send screening. Like, there's a very low risk to getting the blood drawn. And if you're worried, why not get a TSH and a T4? And it kind of settles the issue. Ultrasound depends on the exam and how comfortable you are with the team as far as, not overreading or underreading the ultrasound. But again, there's no harm outside of someone misreading, which we hopefully don't, we can't use that. We just have to think about it. You can't use it as a reason not to do something. You just have to ask them what their experience is to do surveillance if someone's worried. So there's always reasonable to at least get a baseline set and to decrease your worry, your concern.
Thank you. The other question is for myself. How do you feel about tissue regrowth? I had a subtotal when I was 18 and then a total when I was 2009, one done at St. Chris, one done at UPenn, just so you know, the highest level possible.
Yeah.
And I have had a history of regrowth since 2015. At what point what symptoms am I looking if it needs to come out, or, does cancer grow on regrowth?
So yeah, I guess it depends what's regrowing. So when you remove the thyroid, whether it's a lobectomy, and then we call it a completion if you have a second one, because I would guess the second surgery was trying to get rid of the whole thyroid. Is that true?
Yes.
Yeah. So a total thyroidectomy, the total should be in quotes, because total is never 100%, right? So surgeons, including the people at Penn, are careful. They don't want to damage a nerve. And so there's typically going to be some cells left over. For patients with thyroid cancer, a decade ago or more, we would use radioactive iodine to ablate to destroy any of the remaining thyroid tissue. In 2016, and probably even before, when the ATA published the third version of the adult guidelines, people started saying, well, you can have some regrowth because they're probably normal cells. And even though radioactive iodine is a low risk, if you're not benefiting from it, so they're just normal cells growing, not everyone should get radioactive iodine. So we have many patients that have had a total thyroidectomy that have cells that then grow. So it depends on what's growing, and that's based on the ultrasound. If it looks like normal thyroid healthy tissue, that can continue to be followed. And then for our thyroid cancer patients, we look at the thyroglobulin level, and it depends what that's doing. And using those two things, and you say, what should you do about it? And oftentimes you'll biopsy it before you make any decision as far as procedures. And so you could biopsy it and say they're normal cells. Well, if they're normal cells, then you just need surveillance. If they're abnormal cells, then you'd think about, what should we do? Should we go back for surgery, or should we use radioactive iodine to help destroy what that small amount is. The third option, which we use at CHOP, is ablation by biopsy. So you put the needle in and you can use chemical or heat to destroy tissue that's there, that you don't use radioactive iodine, you don't need surgery. So again, it's individualized. It depends what's there, and it's not uncommon to have some tissue that's left, most commonly normal, and the tissue may grow over time. Not uncommon.
Thank you for that answer, Dr. Bauer. I wanted to ask specifically, is there some school of thought that perhaps if somebody's had thyroid cancer, keeping the TSH a little lower with medication to suppress thyroid tissue coming back, like
Yep.
the previous participant was asking?
No, a great follow-up question. In the back of my mind, I didn't talk about TSH suppression, so that's like perfect timing. For patients that have thyroid cancer, we usually, if you don't have a thyroid, you're on levothyroxine, you're on T4 anyway. And the normal range is for a TSH is 0.5 to 4.5. And depending on the extent and the invasiveness of the thyroid cancer, but for all thyroid cancer patients, we usually try to keep the TSH closer to the bottom, closer to 0.5 or so, sometimes even below that, because TSH is thyroid stimulating hormone. That's what it stands for. And we don't want any cells to be stimulated to grow. So it's a perfect question. If you have your thyroid removed, it's thyroid cancer. We keep the TSH a little lower, suppressive therapy. We're talking about suppressing the TSH. If it was benign, we do replacement. That means just keep the TSH in the normal range. If it's 0.5 to 4.5, we usually target 1 to 2 or so as a target for the TSH on levothyroxine replacement therapy. Perfect question.
Okay, great. And I have just one more question. So in a family, mother and father, the child gets PTEN from one of the parents, and now the other parent shows up with a BRAF mutation and has invasive thyroid cancer. In your opinion, if you have historical data, would that bring up that child's risk and maybe warrant going quicker to having thyroid removal? Or I don't know, tough question.
No, it's a great question. So BRAF mutations in thyroid cancer are limited to the thyroid cells. They're not germline, so they're not passed between different individuals in the family. PTEN, just as a matter of discussion, is sometimes just limited to the thyroid gland and sometimes is in the germline. So this, today we're talking about germline PTEN mutations. But we do have patients that don't have a family history of PTEN, and we do a biopsy and remove their thyroid, and they have a change in the thyroid cells only that's PTEN. So that's similar to the same situation with BRAF. So that doesn't change the family risk, or that person that down the road, they decide to get married and have kids. It doesn't increase the risk based on the BRAF of having that. You'd have to have 3 first-degree relatives, non-PTEN related, that has familial thyroid cancer, and BRAF is usually not a player. So increasing the risk to the family, no. But there are patients that will have, most patients with PTEN just have PTEN, and most patients with BRAF just have BRAF. BRAF is one of those invasive changes. Typically on ultrasound, it looks invasive, so it's darker, it has irregular margins, it may have lymph node metastasis, and typically it has those bright spots, microcalcifications. And so, again, it doesn't change the PTEN surveillance for the child unless their ultrasound looks unusual. So we do have a patient in our practice who has PTEN, who actually had a nodule that did not look like a PTEN nodule. It was irregular, it had microcalcifications, and the nodule was BRAF positive, and they had papillary thyroid cancer. So thyroid cancer is not uncommon, and PTEN is less common, but it is possible to have a less common, syndrome in the family and get a common thing. And it's just weird that they happen to both be related to thyroid cancer, but that occasionally does happen, either 2 different people in the same family or even in the same person. So both those things are possible, and kind of a complicated response, but I hope I answered your question. Does not increase the risk for the patient as long as their ultrasound looks like a PTEN ultrasound.
We have one, Jill Lovell online, and you've had your hand raised for a minute if you want to jump in with your question.
Thanks so much. Thank you for this presentation. It's super timely and informative. I have an 8-year-old child who recently did have to have a thyroid biopsy. We're at Phoenix Children's because his nodule doubled in size and just looked dicey. He has a lot of nodules and he's only 8. Does there ever become a point when ultrasound, you're just kind of like chasing a cloud of there's so many nodules? Do you know that you're seeing the same one every year? Do you mind talking about that? And then I had one sub question about lymph nodes.
Again, another great question. So patients with PTEN have multinodular goiter, right? They can have more than one nodule, both on each side. In general, if the nodules look similar on ultrasound, you don't have to biopsy every one of them. So you want to biopsy nodules that look different on ultrasound, or even within the same nodule, sometimes the tissue looks different. So sometimes part of it's darker gray, part of it's brighter gray. So those are all ultrasound indications that if you're going to biopsy, you want to biopsy different things. So if one nodule is biopsied, I would hope the rest of the nodules look the same, because if you're undergoing the procedure, you should biopsy as many that look different. As far as, are you just kicking the can down the road, so to speak? I call it the losing sleep factor. And again, it's a balance of not driving you crazy, not being driven crazy, and not driving your child crazy. Like the balance of that is very individualized. And some people are comfortable having multinodular goiter. They had a biopsy, it was benign, and they just want to keep waiting, both the patient and the family. And some families are less comfortable with that because it's not, not burdensome to need repeat ultrasounds, to always worry that if it's growing, it could be something wrong and they might need another biopsy. And so if they're 8 years old and they already have multinodular goiter, depends on how big they are and how many they are and what they look like. Some patients undergo thyroidectomy. If and when you do that, really important who tests the surgery, because the likelihood is benign disease or non-invasive thyroid cancer, and you don't want to have a complication if you can avoid it. And so I understand it's hard. It depends on where you live and what your insurance is. That's the challenge, I think, for all of our patients. But we can talk offline, and if you want to send me a message, I can try to figure out, if you're thinking about that, what's the best option.
But yeah, and we would definitely want to postpone a thyroidectomy as long as possible. I just wanted to know if ultrasound continue to monitor if there are
and benign
nodules.
And benign things grow. A growth pattern does not change that it's a higher risk. It does change if it's a 20% growth. That's what we usually say. At least consider repeating the biopsy.
Perfect. And then with the lymph nodes, he had microcalcifications in his lymph nodes. Our team said usually thyroid cancer doesn't grow up, if you will. I'm not a doctor. But do you see microcalcifications in lymph nodes in people with PTEN that are just PTEN?
No. So PTEN is typically not associated with microcalcifications. That's usually BRAF or fusions, RET fusions, ALK fusions, other things. And so minimally invasive follicular thyroid cancer and encapsulated follicular variant of PTC are typically not associated with microcalcifications. Classic PTC is. The challenge is that not every bright spot is consistent with a microcalcification. So if you have a nodule that looks low risk and you have a lymph node that looks a little funny, that has a couple of little bright spots, it might just be a lymph node that looks a little funny and has a couple of little bright spots, and they're not microcalcifications. In fact, that's more likely than not. And so again, you can biopsy the lymph node. That for sure conscious sedation, because you'll get away with one biopsy here. If you start poking the needle other places, you're setting yourself up for a meltdown, understandably, because it's uncomfortable. But that can be biopsied. It's just less likely that lymph node, if it looks different than the nodule, is going to have microcalcifications in it.
Okay. Thank you so much.
Yep.
We have time for one more question.
Thank you. My husband had a total thyroidectomy, but his and our children all have PTEN, and my twins have nodules. My husband's cousin over in Sweden died from anaplastic thyroid cancer. Now, he had the PTEN mutation, which I assume is on the same exon as our family. I'm just wondering if we should be more aggressive with biopsy and thyroidectomy with our children based on the history with the anaplastic thyroid cancer.
Right. So that's a really great question. Sorry to hear about your family member. And like I said, most patients have lower invasive thyroid cancer, but there are case reports of anaplastic thyroid cancer in patients with PTEN. And that's why it's not all. We don't have enough cases, and we don't, at least I don't, maybe Dr. Ang doesn't, but it certainly needs more research. Well, like, why does a patient with PTEN in the same family, one person develops such terribly invasive and difficult to treat thyroid cancer, which is in that list that I showed you, differentiated, poorly differentiated. Anaplastic is a step beyond poorly differentiated. It's a terrible cancer with a high mortality rate. So for all the patients in the world in the published literature, there's a handful of patients that developed anaplastic cancer, and we don't understand why that happened in that particular patient and no one else in the family member. So ultrasound can still be used in the family, and if the nodules do not look invasive and the biopsy looks reassuring, then you can continue with normal surveillance. If the biopsy, if the ultrasound looks concerning or the biopsy looks concerning, then obviously that changes the plan. And then again, within family context, a family that has a family member with the same syndrome that had a terrible outcome raises the anxiousness. It raises the anxiousness for me just thinking about it, let alone for the family. And so you may decide to do something sooner, but you don't have to, as long as things look reassuring and you're comfortable, waiting and following based on what the ultrasound looks like, plus minus the biopsy.
Should we avoid, my twins also need braces for their teeth, and they won't do it without doing a dental x-ray. And I've been worried about that. Are dental x-rays safe with thyroid nodules and with that history? It's okay?
Yeah, absolutely. So all of us, starting at whatever age, till 100 years of age, should have the covering of our thyroid during dental x-rays. So as long as you cover the thyroid with that lead shield, there should not be an increased risk to getting the x-rays, and super important, to make sure that the dentist and orthodontist have all the information they need to do the right thing for braces. So absolutely safe. Just make sure you protect the thyroid like all of us should protect our thyroids.
Thank you.
Thank you so much, Dr. Bauer. I apologize we didn't get to everybody's questions in the chat, but we are so grateful to have had you here today and so grateful to work with you. Thank you.
If you send me the chat questions, I can try to go through them and send them back to you, Suzanne, if you want. Just let me know.
That'd be great. Thank you, Andy. I can send those over to you.
All right.
And,
Thanks again, everybody.
Thank you so much. And we're going to take a 10-minute break now, so we will resume again at 10:30.